Hello, my name is Gideon Hirschfield. I am a hepatologist from Toronto Centre for Liver Disease. I'm joined today by Associate Professor of Medicine, Dr. Palak Trivedi from the University of Birmingham, who is an expert on autoimmune and cholestatic liver diseases. Hello, Palak.
Hi, Gideon. Thanks for having me.
As you know, we've both just got back from AASLD 2023, which was really a very exciting meeting. And today I thought we should take the opportunity to catch up and talk about some of the new data that came out of that meeting for people living with primary biliary cholangitis. So what stood out for you, Palak, from AASLD about new therapies on the horizon for people living with PBC?
So yeah, thank you very much for sort of asking that question. It was a really exciting meeting. The things that were most impactful from my point of view were the phase 3 trial results from the response study and the ELATIVE study, the latter of which is now obviously fully published and we can see the results online. And the reason that these were exciting results, these are next generation PPAR agonists from clinical trials done to regulatory standard. It is only a few years ago that we got the first second line therapy in PBC in the form of obeticholic acid, which is now licensed, and we've now got newer agents which are hopefully will be available to patients in the near future. The trial results themselves also look to normalize biochemistry, not just reduce alkaline phosphatase values, which is the traditional clinical trial endpoint in prior PBC clinical trials. And one of the things that came out of these sorts of meetings is that we are now really trying to move the goalposts sort of towards that endpoint. And these different trials are seeking to attain normalization in biochemistry and have achieved it in sort of to different degrees, which I'm sure we'll talk about as this afternoon wears on.
Okay, and was there any of the data specifically about those two registrational studies that stood out for you?
So the first thing to say is that both of these agents, in the response trial they looked at a highly selective PPAR delta agonist. In the ELATIVE trial they looked at a PPAR alpha delta sort of agonist, and both of these agents were shown to lower serum alkaline phosphatase values and other parameters of biochemistry very early on, as early as 3 months into the treatment course. So that's an early rapid reduction. That's the first thing. There were also improvements seen in other liver biochemical parameters beyond those encompassed in the primary endpoint of those trials. But again, a rapid reduction seen in sort of transaminases in both of these studies. They both showed normalization in alkaline phosphatase values to different degrees. The ELATIVE study showed it from memory, about 15% of patients attained that endpoint. And in the response trial, I think approximately 25% of individuals was seen to normalize their alkaline phosphatase value. And this is not something that we can easily or readily achieve in, say, a 12-month period with currently licensed agents for patients with PBC who do not respond to ursodeoxycholic acid. So it really is a new and exciting era for these individuals.
Okay, and then when you think about how you might explain these new therapies as they become adopted into practice, how would you explain to patients how they work and why PPAR agonists appear to be a step forward for therapy, we believe, in years to come?
So when we start seeing newly presenting individuals with PBC, in the current day and age, you would hope that everybody receives first-line therapy with ursodeoxycholic acid. Now, this is the quintessential bile acid therapy that we've been using for years as hepatologists. What we try to explain, first of all, was what ursodeoxycholic acid does. What we understand or believe that it does. It sort of enhances bile flow. It reduces apoptosis on biliary epithelial cells. It enriches the bicarbonate concentration in their bile, which protects their biliary epithelium. If and when we add in current second-line therapy with obeticholic acid, we explain to them that this particular agent, amongst other things, targets the rate-limiting step of bile acid synthesis. So it reduces the amount of sort of bile production, and it also has certain other properties such as antifibrotic effects. when we talk to them about these newer next generation PPAR agonists, we say these are additional bile acid therapies that work in a slightly different way. One of the ways that I explain to patients is that it increases the upregulation of certain biliary transporters, which are responsible for bile salt export, for enriching the bicarbonate concentration further. So that's the first thing. The second thing, I explain that it's very likely to have a synergistic action together with ursodeoxycholic acid, and possibly, although we don't sort of have high quality evidence just yet, but they may have potential to enhance the effects of other currently licensed therapies like obeticholic acid.
And there was a lot of discussion at the meeting around symptoms in these clinical trials, and both clinical trials were looking at biochemistry and symptoms. Why would PPAR agonists help the symptom of itch?
That's a $1 million question. So we don't understand fully why people with PBC develop itching. We recognize that there are certain individuals who itch because they've got very high bile bile acid values. Other people itch because they've got high enzyme activity, an enzyme called autotaxin. And other individuals, so what we see is that there's a circulating biomarker of itch called interleukin 31, which is lowered by PPAR agonists, such as the two agents that were under clinical trial in this particular study. So what we see is that these circulating markers of IL-31, which is a driver of itch recognized in the dermatology field, that is lowered when we give people a PPAR agonist, and that may be one of the reasons why these agents may induce a reduction in itch severity. In the response trial, which was, to my understanding, statistically powered to detect a reduction in itch severity according to the numerical rating scale, there was a significant reduction in the NRS. In the ELATIVE study, which wasn't statistically powered to detect a change in itch severity, they did detect a reduction in itch, but according to a different tool, to the PBC-40 itch domain. So both of these certainly have a signal at attenuating itch, which is certainly troublesome for our patients.
I mean, and I think the other thing that is very important for patients is safety. We've obviously learnt a lot about the use of obeticholic acid and the upsides and the downsides of obeticholic acid. What is your takeaway from the safety that you saw from the new therapies described at AASLD?
So the first thing to say is that in these clinical trials, and it's important to say that these clinical trials would run over a relatively short time in the lifespan of an individual. These are trials that are run over a couple of years, not decades. So we will still learn a lot more about these agents from real world studies. But there were no major safety signals that that were concerned or surprising to me. The first thing to say is that unlike some of the currently licensed therapies for PBC, we didn't see huge increased cholesterol values, for example. That was the first thing to say. Secondly, there has been a concern with some of the current off-label or off-license PPAR agonists in terms of elevation in creatinine values, and certainly causing some elevation in ALT and AST values. We didn't see huge, so significant signals in terms of elevations in these in these parameters with these studies. So from a safety point of view, I'm somewhat reassured by the clinical trial results. One of them, of course, has been published in its full form. The second will soon follow, so we can interrogate that data further.
And so, as we build the the factory which we can use to treat our patients with PBC, what are your thoughts about so-called combination therapy? Have you got thoughts on why FXR agonists and PPAR agonists are synergistic, at the level of, biology and the patient? And did you have any thoughts about some of the emerging clinical trial data about FXR agonists and PPAR agonists together that you've come across?
Yeah, certainly. So there was a late breaker presented as a poster at the meeting, which looked at the combination of an FXR agonist in obeticholic acid and current repurposed off-label PPAR agonists in the form of bezafibrate as part of the a fixed dose combination. So that was a result of a clinical trial conducted by some of our colleagues. The exciting thing about this trial data, they're seeing normalization rates in biochemistry up to about 65% of individuals when it comes to alkaline phosphatase, which is something that these therapies in isolation are not able to achieve. So that is certainly some very exciting data. We don't currently have any information as to whether these newer next generation PPAR agonists combined with a obeticholic acid and FXR agonist will achieve the same thing. We hope they do, and sort of and biologically there is rationale for that, which I'll come on to in a second. But certainly, these newer agents, that is really the next step, and see what the optimum PPAR agonist combination with an FXR agonist and ursodeoxycholic acid is likely to look like, particularly for our high-risk patients who don't respond to monotherapy.
And scientifically, what do you think is going on at the level of the cell?
So at the level of the cell, I mean, so again, these are sort of very important sort of questions to answer. When we study these agents in isolation and we look at the biliary transporter expression in isolation with FXR versus a PPAR agonist, there are some differences. As I mentioned earlier on, FXR primarily sort of affects the rate limiting step of bile acid synthesis, so reduces bile acid flow. So you would think logically that as well as increasing bile acid egress and reducing bile acid production, the toxicity from bile acids to the biliary epithelium is lowered, the apoptosis that these biliary epithelial cells experience is lowered. When we add an FXR agonist, we are actually increasing bile salt efflux, as well as increasing the phosphatidylcholine phospholipid membrane that packages these bile salts, and that leads to some degree of protection to the biliary epithelial cells even further. We also see some detoxification through other sort of channels like CYP3A4, which is another cytochrome, sort of P450 sort of component. So you're detoxifying bile acids with PPAR agonists, as well as reducing the production of them with an FXR agonist. That's what my take on the sort of on the biology is so far.
I agree. I think it sounds like they're both doing the same thing, which is protecting the patient's biliary epithelium and hepatocytes from bile acids. And FXR is increasing BSEP, and PPARs are a different nuclear receptor pathway that's affecting bile acids and lipids. So when we think about that actually puts it all to be quite exciting for patients living with PBC. New therapies that improve biochemistry and symptoms, and maybe in the future even more opportunity to bring a number of new therapies together. So how would you then, as an expert treater for PBC, summarize the treatment goals now for people living with PBC as 2023 comes to an end?
It's an excellent question, and I think our treatment goals are moving towards normalization, not just in alkaline phosphatase, but normalization in all biochemical parameters. Now, is that something that we are likely to achieve in all patients that we see? I don't believe so. And is it something that we need to achieve in everybody with PBC? Again, I don't think so. But our high risk individuals, those people of young presenting age, and we can debate what the definitions of young are, but certainly people below the age of 60 years old, those individuals who have advanced or progressive fibrosis, sort of by our current non-invasive technologies, fibro score above 10 has been cited in the literature recently. Those are the people where we're really going to be targeting normalizations with combination therapy. Individuals with minimal or no fibrosis progression, those of older presenting age, I think the older criteria, such as that presented in the POISE trial from many moons ago, those will still be acceptable, provided that we can sort of attain those goalposts. And pushing therapy after therapy in that group, who are unlikely to develop significant liver events, is perhaps not necessary.
Okay, so personalized care, but identify those at greatest risk and aim for normal tests. And what did you feel the treating physician should be doing about symptoms?
I think that the symptoms need to be addressed in parallel to trying to attain biochemical normalization. So the individuals that are currently very difficult to control their disease are individuals who are biochemical non-responders to urso with significant itch, because the only licensed second-line therapy at the moment is known to exacerbate itch in a sizable proportion of individuals, and some studies quote sort of approximately 1 in 3. So it's whether with these newer agents, when you have somebody who's a biochemical non-responder to urso alone, if we give a PPAR agonist to this individual instead of an FXR agonist as a second-line therapy, when they have difficult to treat itch, that is how I see that these therapies will be positioned. So in your biochemical non-responders with itching, these will very much sort of be the second-line therapy of choice. And if you get somebody who has not normalized their blood tests with urso and obeticholic acid, and certainly if that is the intended target, then these newer PPAR agonists will again be brought in as a third-line therapy in combination with existing agents, irrespective of whether these individuals have itching. We don't really have good treatments yet for other symptoms and quality of life domains. For example, cognitive impairment, fatigue. These things are still an unmet need in individuals with PBC, and I don't believe the current therapies have really answered that question.
Okay. So, I mean, really, what you're highlighting is that the way the field is moving is towards normalization, but on a personalized level in terms of the laboratory tests, and a real effort to try and improve and normalize patient symptoms. And we really got tools now which will target itch and beyond. And so with that kind of summary, how would you be looking ahead? What do you see within your own program and the collaborations that you sort of forge? What are the remaining scientific and patient unmet needs for people living with PBC?
So going back to the topic of personalized medicine, it's identifying which individuals are likely to benefit the most from a particular second, or dare I say, third line therapy. Can we save time? Can we minimize biliary and hepatocyte damage by choosing the right therapy for the right person at the right time, like we do in other immune-mediated conditions such as inflammatory bowel disease, rheumatoid arthritis, and so on and so forth? Can we identify the groups of people who are more likely to benefit from a new next generation PPAR agonist versus the current standard of care with an FXR agonist? Is that possible? What are the parameters? Is it something as simple as the height of their biochemical parameters when they start that therapy? Or is it going to be more of a molecular signature that is only able to be assayed in a research laboratory outside clinical practice? So that is a key unmet need alongside the difficult to treat symptoms that I've mentioned.
Okay. And what would be the first Nobel Prize in PBC if you were going to look for one big scientific win for PBC?
Well, if we are able to normalize blood tests in everybody with a particular therapy, I think that would certainly be worthy of a Nobel Award. And certainly if you're able to give time-limited treatment to somebody without need for long-term intervention, i.e. you've completely switched off ongoing biliary epithelial cell damage, I think that would certainly be worthy of such a prestigious award.
So with that, I'll thank you, Dr. Trivedi, for a really dynamic discussion about where PBC is at, where it's going, and where we'd like it to reach. And just to say, I think both of us who look after a lot of patients with PBC are very excited by this new therapeutic data that's emerging, and we're very excited by ASLD. And I'll thank the audience for listening to us today talking about PBC, and I look forward to doing this again, Dr. Trivedi.
Thank you very much, Dr. Hirschfield.